My name's Kevin Hedges. I'm an occupational hygienist with the Occupational Health Clinics for Ontario Workers. I'm also the International President of Workplace Health Without Borders. So a number of the speakers that we're going to be presenting today have also presented through Workplace Health Without Borders. And I encourage you to look up Workplace Health Without Borders to find out more about us. But it gives me great pleasure to open this session today. And we have some really great international speakers. Lisa Brosseau, first, who's a retired professor from the University of Illinois School of Public Health. Lisa has done an incredible amount of work in this area. She's also been an educator at the University of Minnesota Public Health, where she directed the industrial hygiene program. And her early research focused on performance of respirator filters. She continues to serve as a mentor and tech advisor on research projects and also consults with CIDRAP. Dr. Brosseau has authored more than 100 peer-reviewed publications. That's our first speaker. Our second speaker is Deborah, or Deej Gold. Deej is a CIH, and she's worked for OSHA for 20 years. And she was the lead in developing the OSHA standard on the Aerosol Transmissible Disease Standard. She retired in 2014, and she worked as a deputy chief for health, and in 2014 and she retired, and she continued to work with unions. Deej is second, and then we've got Professor Cherry for the Institute of Occupational Medicine. I don't actually have my slide up, John, so I'm just going to have to ad-lib this. So John Cherry has been in the field for many years. He's a professor, and I believe he's with Harriet University as well. And he's a well-renowned practitioner in the field of occupational hygiene. And when I show my introductory slide, you can see more about John. The last speaker is Simon Smith. Simon has recently retired after a career in respiratory protection research for over 35 years. This started with doctoral work on sorbent media, followed by employment with respirator manufacturers. And Simon or Dr. Smith works closely with the ISRP and also the ISO working groups, international standards for respiratory emergency responders. He's also had a lot to do with the Canadian standard and the bioaerosol working group. He's also chair of the AIHA Respiratory Protection Committee. So what I'll do is I'll just quickly share my screen there. Hopefully, just share my screen just to have an introduction here. So really, like I said, I've introduced the speakers, and this is really, yesterday we had a fabulous session debating the science with some really well-renowned international speakers. And so the idea was just that we debated the science around aerosol transmission. And now we're sort of looking at the hierarchy of control, the hierarchy of prevention, also introducing control banding, and the role of infectious dose and the hierarchy of prevention. And as I said, these are the speakers that we have. Lisa's closely aligned with CIDRAP, the Minnesota Center for Infectious Disease Research and Policy. Deborah Gold has a lot to do, has led the development of these standards, and I provided hyperlinks in the introduction slide. And Professor John Cherry, Harriet White University, Principal Scientist of the Institute of Occupational Medicine. So he's doing a lot of research at the moment through IOM and through the university to evaluate the effectiveness of novel workplace interventions to protect healthcare workers from the coronavirus. As part of this research, is working with a group of clinicians, engineers, and others to develop and test a ventilated headboard for use in health and social settings. And as I said, Dr. Simon Smith is talking about respiratory protection, selecting effective respiratory protective equipment after that. And then there's a Q&A session. What I'll ask is each speaker, if they could try and keep it to 15 minutes, because we want to try and keep enough time for Q&As. Without any more information from me, I'm going to hand you over to Lisa, Dr. Brossu.
So thank you. I don't know if people can see me or not, but thank you very much for the invitation to speak today. And I would like to thank Paul Hewitt for reviewing my slides. This is not an area of necessarily of expertise, although I am quickly learning a great deal more about exposure assessment, modeling, and using infectious dose as an idea as a way to illustrate the impact of different interventions. So I hope
we can see your slides, Lisa.
Thank you. So as Kevin mentioned, I did work as professor at the University of Minnesota and the University of Illinois Chicago until up to 2 or 3 years ago, and was retired doing a little consulting. Of course, now I feel like I'm much less retired than I was. I have published several articles on the Minnesota Center for Infectious Disease Research and Policy website, one talking about aerosols in the context of this new organism and pandemic, another talking about the differences between face coverings and surgical masks and respirators, and the third talking about decontamination. So I will direct if you're interested in more information about those subjects, you can certainly go to that website. Let's see if I can get this to move along. There. So what I'm going to talk to you today a little bit is what could we do if we thought about infectious dose? And infectious dose has been around for a while, but it's been more used in the context of tuberculosis, and maybe a little in the context of influenza, but it's not received a huge amount of interest and research for things like SARS and MERS and SARS-CoV-2. So, but I think there's more attention being paid to it in the recent past, and I think people are beginning to understand that there must be there must be a dose issue or some relationship with respect to concentration and time. And so for SARS, we thought a lot of it was nosocomial transmission, and the highest risk of infection seemed to be during aerosol generating medical procedures, where anyone standing around not wearing a respirator, a well-fitted respirator, was infected in small spaces. The expectation was that SARS-CoV-2 would have the same kinds of features, and so there has been attention for aerosol generating medical procedures. But in COVID-19, we are seeing a lot higher attack rates in other settings, but again, they're indoor clusters. And so both of those, to me, as an industrial hygienist, suggest that SARS and COVID-19 are outbreaks and pandemics are related somehow to dose, and dose is the function of both concentration in the air and time, and that's why I've started talking more about infectious dose. And I'm not going to spend a lot of time talking about aerosol transmission. I've talked about that in many other settings, and I think more and more today we're beginning to understand and come to the conclusion that aerosol transmission, meaning inhalation of small particles, small infectious particles near a source, not necessarily far away from a source, is really a key feature of transmission for this organism. I've listed here, Matt Evans has a paper, it's a preprint now, I believe it's in review, called Avoiding COVID-19 Aerosol Guidelines, and he has used the concept of infectious dose and derived from novel H1N1 and SARS risk assessments. He's derived an estimate of about 1,000 virions, meaning individual viruses, as a dose. Now, we don't actually know what the dose is for COVID-19, but we do understand that there has to be something about the number of organisms that you are exposed to. It isn't probably just one virion, and it may be less than 1,000. We don't really know. And this obviously it's where those particles land in the lungs. So what size are they, and how likely are they to deposit once they make it to different places in the lung? Well, that will have an impact, as well as what size particles and what concentration particles do people generate to start off with. Today, though, we have a lot more information about that. Here's another recently published article by Lydia Maraska and colleagues called Estimation of Airborne Viral Emission. And they're using a concept called quanta, but quanta is basically another way of talking about infectious dose. And they describe, all of the things that you need to understand to derive infectious dose. And obviously, we don't have a lot of this information. We do have some information about the viral load, meaning the number of RNA copies per milliliter or nanoliter in sputum for SARS-CoV-2 from a small number of studies where people have been measuring in nasopharyngeal and oropharyngeal and sputum samples. We do know something about viral load, breathing, talking, coughing, sneezing overall for people who are healthy, and we have some data from people who are infected with influenza. So we can make some analogies. We do know lots of information about the volume of air that people exhale, the breathing rate of people who are working at different work rates. We do actually know some information about the number of particles that people emit and the particle size, and thus the volume of those particles, which is a function of diameter of particle. So we have a lot of information from other studies and from studies with healthy and infected people that are useful in the context of this. So I'm going to build on top of mostly what Dr. Evans, Matthew Evans at MIT has published, and also what we know in terms of industrial hygienists for modeling. So Paul Hewitt and Gary Ganser published a number of very useful articles, models for nearly every occasion. This is just the reference here on the bottom is just one of, I think there are 5 or 6 different articles that talk about different kinds of models. This first one talks about one box models, very simplistic models that essentially treat a space as a single box. And for many years, industrial hygienists have used these simplistic ways of thinking about concentration, especially under a steady state situation. And a steady state situation would be when you have an industrial process that's creating or generating an aerosol. Well, if you think of people as aerosol generators, which they basically are, and they're a little more mobile than most industrial processes, but that doesn't change the fact that they are in a room generating particles. And so you can use these same steady state concentration equations to derive, and what we know about ventilation to derive what the concentration might be, and then compare that in the context of an exposure limit, which is sort of what an infectious dose is. So I've shown the concentration is basically a function of generation rate, virions per minute, divided by the ventilation rate in cubic meters per minute. And I've listed, this comes from Matt Evans' work. He's gotten these from a lot of published studies of how much volume of saliva do we generate during an individual sneeze or a cough, or during talking over some period of time. And you can, from that information, derive a virions per minute generation rate. Using that information and what we know about ventilation. So in the context of ventilation, what we often know is what we can surmise on the basis of the type of room that we're considering, there are guidelines for how many air changes per hour a particular room should have. That doesn't mean it necessarily will, and so it's better to measure the air changes per hour. But if we can't, we can at least indicate what it should be based on guidelines. And we can easily measure volumes of the room, simply the length, width, and height. So I'm going to use as an example of the typical volume as I found on the internet for a hotel room. My example is going to be a hotel worker needing to enter that room and be safe in the context of cleaning that room after someone has been there for some period of time. So the room volume I found on the internet is about 300 cubic meters. And I couldn't find a lot about guidelines for it, and probably because I didn't look hard enough, but I did find some indication that the air changes per hour in a hotel room should be 5. That does seem high, but because residential spaces are generally around 2 or 3. But I'm going to go with it on air changes per hour of 5 for now. And you can basically use this equation, the ventilation rate equals the number of air changes per hour times the volume of a room, to arrive at what Q would be, the ventilation rate. And I've worked that out here. So giving this example of a hotel room, what's the concentration in this 300 cubic meter hotel room with 5 air changes per hour if you have a guest who's infectious, who's staying overnight? And because we have so many people who are infectious and don't know it, they're asymptomatic. I'm assuming they're not doing a lot of coughing and no sneezing. So, but they're there for quite a long period of time, 12 hours. So I came up with sort of a profile. They're mostly breathing, doing a little talking. I assume they might call somebody up and talk on the phone for a little while, and maybe some periodic coughing. And so you can derive an overall generation rate, and then use that C equals G over Q, that first equation I showed, to figure out what the concentration would be over some period of time. And this is a concentration, as I said, steady state, so it does take a little while before you reach this concentration, but then it maintains. You've got a constant generation of particles, and you have a constant removal of particles by some form of ventilation. Well, if we consider, what that means with respect to a hotel worker, we can figure out how long should they wait for that room to clear, knowing what we do about the volume of the room and the concentrations. And that's this equation here, where basically the time is equal to, is a function of the volume of the room, the ventilation rate, and the initial concentration. And I assumed we would be looking for a concentration that's, say, 0.1 virions per cubic meter, very, very low. So you can use this equation to figure out your wait time, and it turns out to be 84 minutes. So once the person checks out, the hotel worker needs to wait an hour and a half, at least, in order for the concentration to become low enough to be safe enough to enter. And this is assuming, of course, that this hotel worker is cleaning many rooms. So you want this concentration to be as low as you possibly can. That she or he could probably enter this room and work for an hour and not get an exposure that would reach the infectious dose. But you have to keep in mind this person has many other potential exposures during the day, other rooms they clean, other places they go, transportation they're on, the interactions they have with their family. And so I would suggest for this particular exercise, I'm suggesting we want to assure that they really are dealing with a very low concentration. There is, it turns out we've had a lot of the conversation about the aerosol transmission and infectious dose and how to figure out how to protect people has been had in the context of healthcare and Mycobacterium tuberculosis. And I went back to the 2005 CDC guidelines for preventing transmission in healthcare settings and discovered that there's actually quite a lot of very useful information there relevant to ventilation, including this quite nice table that indicates how long do you have to wait to get 99% removal or 99.9% removal based on the air changes per hour. And so you don't even really need that equation. And you can go back and work it out. You'll see that it is a fairly, you don't even need to know the volume necessarily, as long as you know the air changes per hour. I was asked to think a little bit in the hotel example about mixing, and so I did a little research, because mixing factors and safety factors have been used for many years. This well-mixed box model that I'm talking about assumes perfect mixing, but it's true that might not always be the case. So some guidelines suggest that you add this mixing factor basically to adjust your ventilation rate. And it ranges somewhere between 0 with no mixing to 1 perfect mixing, where generally we put values of 0.1 to 0.5. But it turns out, I think mixing factors have fallen out of favor a bit. They're not used as much in modeling. We have better methods of modeling. And if we do think that the one box model is not appropriate, there may be other approaches that could be better. And we also have computational fluid dynamics modeling, which really can take into account many other variables. So as much as this has been a useful way to incorporate lack of mixing or poor mixing in a room, it seems it's somewhat out of disfavor, but I did want to mention it. So we can also use an equation and think about what's the exposure. So what if you have two people staying in the room, one person's infectious and the other is not? You can see how this can easily be applied in workplace settings or other public settings. So we know the steady state concentration is 137 virions per cubic meter. Dose is basically a function of concentration and breathing rate and time of exposure. So if you had somebody sharing the room with this person 12 hours, breathing at a rate of about 10 liters a minute or 0.01 cubic meters per minute, you can work out that they will have a dose of 986 virions. If you recall, 986 virions is not that far off from the 1,000 virions that Matt and others have suggested may be our infectious dose. And I should have included, this is both from Matt and Pat and Paul Hewitt, who gave me this very nice graph to show you the probability of infection. So you can use this equation, 1 minus the exponent of negative dose over that you've calculated over the infectious dose. And again, I assumed that the infectious dose was 1,000 virions. And so you can see that at a dose of 986 virions, you have a 62% chance of getting an infection. So in the context of interventions, and there are many other examples I could work, I just wanted to illustrate how once we do figure out what infectious dose is, or if we just use what we have derived from SARS and influenza for now, there are many ways to use that information to figure out what concentrations might be, what wait times might be, and to explore the differences between the impact of different interventions. So we could look at how many people are in a room, and maybe one of the source controls could be to say you can only have a certain number of people staying in a room. If we could screen guests and actually prevent those who are exposed, who are asymptomatic and infectious, that would be, of course, another really good source control. We don't have those methods yet, but maybe we will. Of course, the thing that most of us are going to be relying on in the context of occupational health are pathway controls, and that has to do with better ventilation. So one of the things that could be done, if it's possible, would be to increase the ventilation rate, which would decrease your wait time. We could possibly add a portable air cleaner to the room. That's a way of increasing the ventilation rate and also cleaning particles out of the room and thus decreasing wait time. You could limit the amount of time that somebody spends in the room cleaning it. And you could also limit the number of rooms that were clean. Those are just some very preliminary ideas of interventions. There are many more that we could think about in the context of this and any other workplace setting. But what I'm hoping to illustrate is that there are some modeling, fairly simple, easy to apply modeling approaches that can give us some picture of what exposures are like and what the impact of interventions might be. And that's all I have to say, Kevin. Let's see, I guess I need to.
Thank you so much, Dr. Brosseau. And I just wanted to preface this a bit more. This whole session is around the hierarchy of controls approach. So the way that it's actually staged is Lisa has sort of talked about, you know, the assessment of risk and then what kind of controls need to be put in place. And so, you know, the American Society of Heating, Refrigerating and Air Conditioning, ASHRAE, have actually recognized that the coronavirus is airborne. So they've provided a position on that. So this whole session is really looking at the, you know, the hierarchy of control and, you know, ventilation as an engineering control. And then we also with Deej, who's going to be presenting next, it's looking at primary prevention and regulations of primary prevention. So if I can now hand you over to Deej Gold, and she's going to be talking about the California OSHA ATD. So over to you, Deej.
Okay.
And see your slides, fabulous.
I'm beginning, there we go. Hi, can you see those slides?
Yeah.
And you can hear me? Okay, excellent. Well, thank you, Kevin, and thanks to the Occupational Health Clinics for Ontario Workers for inviting me to participate this morning, morning for me, anyway. I want to make it clear that although I worked for CalOcean in developing this standard, and I am not speaking for CalOcean today, and this presentation isn't intended to represent the agency. One of the reasons I'm really excited to be at this webinar is because our ATD standard has many roots in Ontario. Although in 2003, healthcare workers who are over 40% of the Toronto SARS cases were not asked whether they wanted to participate in research on how workers get exposed to aerosol diseases, it would be more than a shame if we didn't learn from it. There are several specific provisions of our standard that are based on either the SARS Commission report or based on the individual studies that arose from that epidemic. For example, from the study on critical care nurses, we learned that although N95 filtering face piece respirators were more effective than surgical masks, that there may be a need for a higher level respiratory protection for AGPs. So the ATD standard requires, with some exceptions, higher level protection for aerosol generating procedures. We learned from the study on paramedics in Toronto that we needed to specifically address protecting emergency medical services. We also learned that calling underprotected workers heroes doesn't actually prevent them from getting sick. And possibly most importantly, we learned the precautionary principle, which in our standard is addressed by requiring airborne infection isolation and respirator use for what we termed novel and unknown pathogens. And this is a quote that you guys are probably more familiar with than me from the SARS Commission report that talks about the importance of the precautionary principle in protecting workers. In 2003, there were insufficient respirators in Asia and around the world to deal with the threat of SARS. After that, respirator manufacturers said that they had established a system that would prevent further shortages. Prior to the 2009 H1N1, the fear of pandemic avian flu caused the US federal government, I believe governments around the world, as well as states and local agencies to stockpile equipment. Emergencies including 9/11 and Hurricane Katrina in the United States led to the Hospital Preparedness Program grants, which gave money to local governments and directly to hospitals to buy equipment and for an emergency. There were many multi-agency drills, exercises, and tabletops. California brought over 50 million filtering face piece respirators for the state stockpile. Then H1N1 occurred. Hospitals ran out of respirators within less than a couple of months. It took us several months more, plus the threat of a strike by the nurses union, to convince the state to release a portion of the stockpiled respirators. Maybe because they considered these all to be once-in-a-lifetime events, and they considered that the H1N1 was that lifetime event, but stockpiles were not replaced. And we can see from this slide, this is just a few of the infectious disease events that have occurred in only a fraction of my lifetime. There are many organizations who deal with infectious disease risks, but only occupational safety and health organizations center around exposures to workers. We have seen that without enforceable regulations, employers do not voluntarily allocate sufficient resources for worker protection in many cases. We have also seen that regulations can protect workers, sometimes simply by their existence. For example, the bloodborne pathogens regulation in the United States. And this is just a chart from the hepatitis B infections in healthcare workers. And as you can see, before the vaccine was first developed, we were over 10,000 new hepatitis B infections in healthcare workers in the United States. And there was a small decline as vaccines became licensed, but we have an enormous decline that occurs when OSHA in 1990 notices proposed rulemaking, and then a further drop so that by the end of the century, they were no longer tracking specific healthcare worker infections separately. And we didn't adopt CDC. Can't just adopt CDC guidelines because they're non-mandatory. They are often somewhat contradictory, and because in many cases public health assessments do not address occupational risk. So in developing this standard, we had to make a number of decisions. The first of which was, of course, what workplaces should we include? We recognized that healthcare was at a specific risk because that's where people go when they're sick. We looked for TB and also included certain congregate living facilities, including homeless shelters, drug treatment programs, and prisons and jails. We also recognized that there was no OSHA standard that applied to biological hazards in laboratories, so we decided to address a little subsection to that. We recognize that in healthcare and related environments, different types of interventions were both possible and necessary. A primary care physician's office or a long-term care facility often does not have an airborne infection isolation room. Therefore, the standard includes different categories of employers with different requirements. And I'll talk in a minute about how we decided which diseases to include. We also had to address problems that we had found with programs for medical services, including failure to report cases to the local health officer, even though required by law, and including following up with healthcare workers and providing prophylaxis. So there's a fairly extensive section on medical follow-up and preventive medical services, including precautionary removal protection, which requires the employer to pay a worker if they have to be excluded due to a potential incubation period that was due to a workplace exposure. And that said, the aerosol transmissible disease looks very much like other OSHA health standards with written programs and engineering controls, hierarchy of controls, work practice controls, and then personal protective equipment. This is the famous OSHA pandemic risk pyramid. And the obvious question is, how do you know it's a pyramid? We are seeing now with COVID that we have many, many clusters of cases in what OSHA's pyramid would consider to be medium or lower risk. Our standard went down a little bit into medium risk by dealing with the congregate facilities like prisons and homeless shelters. And these two slides just summarize how the standard applies. So which diseases? Well, Lisa Brousseau, Don Milton, many of the researchers in this field have taught us that droplets do not conveniently sort themselves out into those greater than 5 microns who fall to the ground and droplets smaller than 5 microns that, if it's the right pathogen, may travel long distances. We know that when we cough or sneeze, droplets of various sizes are emitted. Larger droplets get smaller. Smaller droplets may remain in the air longer for different periods of time and be inhaled. If the pathogen is still viable, you can catch the disease. Even if the droplets don't remain in the air for very long periods of time or travel long distances, they may be inhaled. Thus, the need for respiratory protection for people who are in the near field. Nonetheless, in the political process of decision of adopting regulations, we had to use the current public health paradigms in the United States. And we did divide aerosol transmissible diseases into those that the U.S. Centers for Disease Control and Prevention classify as droplet and those classified as airborne. Certain requirements of the standard apply to all covered diseases, including source control, exposure investigation, medical follow-up, and training. And this slide shows how we actually implemented the precautionary principle in that we included novel or unknown pathogens under airborne infectious diseases and also provided an opportunity for the California Department of Public Health to increase the number of airborne infectious diseases through their recommendations, which is what has happened with MERS. And this shows just a few of the diseases who are listed as droplet under the standard. I think we made some good decisions in writing the standard. Respirators are required for all employees exposed to cases and suspected cases of airborne infectious diseases, not only those who are providing direct patient care, but those who are also in the environment, such as housekeeping. And respirator use is independent of vaccination status. I mentioned precautionary removal, which is used to encourage people to report exposures rather than to hide them because they can't afford to be put off work. We brought in the building code requirements and other engineering requirements for airborne infection isolation rooms, and we required higher level respirators for high hazard procedures. There are strong requirements for transferring or referring cases or suspected cases to facilities that have airborne infection isolation rooms, typically within 5 hours, and also for correct placement of patients in a hospital in airborne infection isolation rooms within that same time frame. In a pandemic, there would not be enough airborne infection isolation rooms and hospital capacity. Alternate procedures are required in the standard when infected patients are maintained in skilled nursing facilities and other long-term care facilities. And there are some things I hope the next people who write a standard like this will improve on. I hope that we will finally get to the place where respirators are required for all aerosol transmitted diseases, because only respirators can protect a healthcare worker from inhalation exposure when they're in the near field. We had no capacity to address schools in this standard, and as we're seeing in recently released guidelines for starting up schools in the fall, there is no general agreement on what would actually protect staff and students in schools. There is currently an effort in California to get the Occupational Safety and Health Standards Board to adopt a standard that would apply to the COVID pandemic in workplaces other than those covered by the ATD standard. So with our imperfect standard, we have accomplished quite a few things. The fact that our standard existed in 2009 helped our friends in the California Department of Public Health and in OSHA keep our state from lowering protections for H1N1. Although OSHA is not always included in emergency operation planning, we have been included more than we were in the past. The standard wasn't designed for pandemics, although it incorporated things we learned from pandemic flu preparedness and planning for healthcare surge. Healthcare workers and workers in related environments are exposed to infectious diseases on a regular basis. One of the first investigations under the new standard was of 2 secondary meningitis cases resulting from a failure to do appropriate exposure investigation and prophylaxis involving employees of 5 different employers. Correctional officers from a state prison were sent with a TB patient to a community hospital but not fit tested or trained to use respirators. In that investigation, we also found that the airborne infection isolation rooms at the hospital were not functioning properly. And we have found a lot of deficiencies in hospitals in their airborne infection isolation rooms and in the operation of those rooms. Our requirements for employers to provide certain recommended vaccines to healthcare workers came just in time to get healthcare workers vaccinated during a significant increase in pertussis cases in 2010. It should be noted that in 2005, the CDC recommended that healthcare workers receive the new Tdap vaccine, but by 2010, less than half of the workers in children's hospitals had received the vaccine. Our standard was used in preparing the state for Ebola, along with the bloodborne pathogen standard, and there are a lot of other examples that I could give. So what about COVID? I believe that we have all learned that what you do not prepare for, you are not prepared for. Nonetheless, the ATD standard has had and continues to have an impact. Despite national and local pressure to go to, quote, droplet precautions, the fact that our standard required airborne infection isolation and respirator use was used by unions, CalOSHA, and public health professionals to maintain as high as possible protection for healthcare workers, although allowances have been made for the severe respirator shortage. One thing that has come up is that some facilities were locking up respirators, providing them only to specific workers as part of dedicated care. They call that prioritization. After it was alleged that some healthcare workers had to perform aerosol generating procedures on COVID patients in cardiac or respiratory arrest without respirators because the respirators had been removed from crash carts, CalOSHA issued an alert that employers must not delay access to respirators in an emergency. As I mentioned, there is an exception to the requirement to transfer patients to airborne infection isolation rooms when it is not feasible for novel pathogens. As we knew would happen in a pandemic, there was insufficient hospital capacity, and COVID patients were required to be kept in long-term care facilities unless there was a medical need for hospital-level care. The standard does require the long-term facilities to use respirators if it keeps these patients and to implement additional infection control procedures. As you are probably aware, there have been many cases among residents and staff in nursing homes in California and around the country. And also, as you are probably aware, despite CalOSHA inspections that have been opened and the application of the standard to the state prisons in California are in serious trouble. CalOSHA was not quick to open on-site inspections, particularly in healthcare, but now many are being conducted, and CalOSHA is also participating in the Emergency Operations Center that was recently set up at San Quentin Prison. CalOSHA has also opened inspections in environments not covered by the standard, including warehousing and meat packing, and we will use standards of general application to address hazards in those environments. So my final point is preparedness. And how do we ensure it? Despite 15 years of the U.S. Federal Hospital Preparedness Program, and despite our experience with H1N1 and preparation for Ebola, in February of this year, barely a month after we even knew about this disease in this country, hospitals were already saying they did not have respirators, and were using that shortage to demand a change in public health guidance. And although that change didn't happen, at least in our state and at the CDC level, the lack of respirators and other infection control measures has put healthcare workers at risk. Although the CalOSHA standard requires employers to have effective procedures to ensure there is sufficient personal protective equipment, both for normal circumstances and for foreseeable emergencies, as well as to prepare for surge events such as pandemics, many, maybe most, employers have not. We knew as we prepared for Ebola that healthcare facilities as a whole did not have sufficient PPE, but it was functionally beyond CalOSHA to make stockpiling happen. There are now 2 bills in the state legislature that would, with fairly different requirements, require hospitals to maintain some stock of respirators and may well require the state to stockpile as well. Stockpiling is a difficult decision. It is hard to convince institutions, including the government, to plan for an event that may happen at some unknown and future time. But we must learn from this pandemic. It wasn't okay in 2003 for healthcare workers to contract SARS from their jobs, and it isn't okay for healthcare workers to contract SARS-CoV-2. Thanks very much for your attention. And I'm going to pass this back to, hopefully somebody will pass this back to the right person.
Thanks, Deej. That was great, and it's fabulous that your expertise is being called on now. And you must feel very good that you played such a big part in developing or leading the standard. And also, just want to say thank you to Dorothy Wigmore for introducing you to us as well. So The next speaker is Professor Cherry. And, just thinking about the hierarchy of control, we talked about, assessing, doing this risk assessment, the primary prevention piece, looking at the legislation, and now looking at more engineering controls around more localized ventilation. I'm going to pass you on to John Cherry now. So thank you, John.
Great. Thank you, Kevin. I hope you can see my screen.
Yes, we can.
Got two screens, so it's a bit confusing sometimes, even for me. I'm an occupational hygienist, and I'm based in Scotland in the UK. We have just begun a project which has been funded by the Scottish Government to look at novel methods of controlling SARS-CoV-2 in health and social care settings. And our project is really at a very early stage, but one of the things that we've become very interested in is looking at novel ventilation systems for controlling the virus, particularly looking at ventilated headboards and control measures for dentistry. And so I'm going to talk a little bit about those two areas. It's really still very early for our project. We haven't really got any results ourselves, but I really want to summarize where we're coming from, what we're trying to do, and what the available evidence is telling us. So, so we, in an ideal world in occupational hygiene, we would like to have some understanding of what the exposure of the people, the workers, is. And what sort of safe level or occupational exposure limit that we want to try and achieve. And then we can apply some sort of controls to reduce the exposures to below that occupational exposure limit. However, notwithstanding Lisa Brosso's very interesting talk that introduced this session today, we really don't have much idea of what the exposure of workers is to this virus. We don't really know what a safe level is, and we don't really know how effective the control measures that we might be selecting are. And particularly in terms of the control measures, the fact that we have multiple routes of exposure, that we may have aerosol exposures, we may have droplet exposure, and we may have fomite exposure as well. So there are these multiple routes, and the effectiveness of control measures in any particular situation will be dependent on the relative importance of these different routes. So, from my perspective, I think all of this bodes that we should really take a precautionary approach when recommending control measures. And that's really, I think, where we're coming from. Now, in the UK, we have regulations which are quite general and generic, and they cover all hazardous substances, and for hazardous substances, it does include the coronavirus exposures that occur in workplaces. And we have, to some extent, discarded this idea of control hierarchy in favor of what we've termed good control practice. There's still a hierarchy because we still mandate that the first obligation of employers is really to either eliminate or substitute the hazardous agent. And the final choice that employers should make is to use personal protective equipment. But everything else within that, we really expect the employer to choose a mix of control measures that gives the best, the most effective and reliable control solution in that particular situation. So that might be using localized ventilation along with personal protective equipment for some aspects of the work, and may be a good sort of combined effort. But really personal protective equipment should only be used where it's not possible to control the exposure adequately by other means. So given that that's the obligation on employers, why are we not seeing more use of local ventilation in controlling this virus? And it's not for want of there being solutions out there, because in many instances, the solutions that we've developed for general and industrial uses can be translated into healthcare settings. And there are other solutions that have been developed over the years as we've tackled various outbreaks of infectious disease. And one good example, I think, are these ventilated headboards that were developed by NIOSH, and they put a lot of effort into trying to validate and ensure that they were appropriate. Just so you understand a little bit about it, that's basically an arrangement where the bed is partially enclosed by a shroud, and that this is then air is extracted through the enclosure into a HEPA filtered system. In essence, it's really a sort of adaptation of a fume cupboard type arrangement that you might expect to see in a laboratory. So NIOSH developed this system and then tested it out using a computational fluid dynamics setup, where they simulated patients coughing and tested for a variety of scenarios. Baseline scenario where there was no controls, and then everything up to a full system operating with the HEPA ventilation. And you can see on the chart here that over time the simulation shows that for case 1, which is the blue line, the concentration slowly drops, but for case 3, which is the fully ventilated headboard, that the concentration from a single cough drops almost to nothing by well, just around about 20 seconds is what the researchers claim. NIOSH went on and further developed further tested the system in practice, and found that the measurements of the containment obtained was very similar to what they'd identified in the computational fluid dynamics test. So really, there's a reasonably good case for expecting that this kind of system would be effective. But I don't know about you, but I've never seen one of these in action. And so there must be something that's giving rise to the system not being applied. Sorry, I've just gone too far. I'm going to, yeah. And that's really, it's stimulated a group of clinicians and engineers and occupational hygienists in Scotland to really try to address this and find out what is the barrier that's stopping these systems being introduced in practice into our hospitals and care homes. The consortium is really an output of the pandemic, because a lot of the clinicians and engineers involved in this are really unable to do anything else, because they're either furloughed or they're just unable to get work. And so it's a great way for all of us to apply our knowledge and energy to try and do something positive in this situation. You can see in the photographs mock-up of some of the NIOSH systems, and the first thing that certainly strikes you is that it looks very much like a do-it-yourself setup. And in fact, actually, when you look on the NIOSH website, they give you do-it-yourself instructions for constructing their system. And I think this is one of the reasons why it's not been widely adopted, because there isn't a proprietary commercial system that is really developed to do this. The other problem, which you can see from the ventilation ducting on the far right photograph, is that it's not really something that's very easy to retrofit into a hospital. Might work quite well for a new field hospital, but certainly not going to work in a conventional setting. And so there are certain barriers to implementing this. And I think the other things that we've identified is that you need to have a quiet and acceptable environment for the patient and the staff to work within. You need to think about access for staff. And in many medical procedures in intensive care, the staff member needs to have almost 360-degree access to the patient. And the kind of setup here just doesn't facilitate that. And you need to have a system that can be safely cleaned and maintained. And again, these systems don't really give that sort of impression. So I think the overall feeling is that we are moving towards something which is much more commercial product that could be retrofitted into hospitals and provide a good alternative for hospital managers. That project is underway, and I'm sorry I can't tell you much more about it just now, but we are really progressing it quite well. The other area that we are interested in developing solutions for in dental surgeries. In the UK, and I guess in most parts of the world, dental operations have been paused and are starting to be reintroduced. And there's been many reviews of the types of controls that are needed to restart this type of operation. I think almost without exception, the ones I've read don't even mention local ventilation. They provide everything else. So, things upstream like testing the patient, how the patient should interact in the waiting area, right through to the use of personal protective equipment. But there's this big gap in the middle, which is the use of local ventilation to try and reduce the exposure. Just by way of hierarchy of controls, I think two of the suggested recommendations are quite interesting, and the photograph shows one of these, which is a rubber dam, which is essentially a barrier between the mucus in the mouth and the tooth that's being operated on. And I haven't yet been able to find any research that looks at the effectiveness of these types of systems in terms of reducing aerosol generation or droplet emissions from the procedure. But I think that seems to be a very promising additional source control that's worth looking at. There's a very recent paper which shows really the problem that dentists face, which is looking at the emission of droplets from dental operations. And in this situation, they carried out simulated operations with a mannequin using fluorescent dye in the liquid that was in the scaling tool that was being used. And they used a matrix of papers laid out in the dental surgery to collect droplet deposition, and then they analyzed these under UV light photographically to determine the area of contamination on each and the intensity of the contamination. And the four Windows type diagrams show the results for three of the conditions that they looked at. One where the dentist is using the tool but has no suction. The second where the dentist is using the tool and this time there is this suction to remove the fluids from the patient's mouth and remove some of the air in the mouth as well. And then the final is the same operation, but this time with an assistant holding the suction tube. And you can see in all three of the diagrams that there's quite considerable spread of the contamination outwards from the patient out to about 1.5 meters, and that regardless of what type of suction was used and how it was done, there is a fairly extensive contamination. But if you look at the quantitative data they have, you can see that with the suction, you get about a 75% reduction in the area contaminated at 0.5 meter. That's the average over all the 0.5 meter samples that were collected, and about an 85% reduction when the assistant was doing the work. The researchers couldn't quite explain why the assistant made that additional benefit, but I think it was speculated that it may be because of more careful use of the suction. Of course, there are lots of proprietary ventilation systems available, sold for dental surgeries, and here are just a small selection of the ones that you can find on the internet. And they're all basically the same type of design, and those of you who have seen welding operations will recognize the similarity in the design of these systems with ventilation for welding fume. The movable arm can be located close-ish to the patient, but to really have much effect, it does need to be really quite close to the patient. And well, we know from other research that this kind of ventilation system is not terribly effective. These are data from a review carried out in 2008, looking at the efficacy of a variety of different local and other types of control. And you can see that for local exhaust ventilation with an enclosure, the median efficacy is around about, well, it's almost 90%, and the 25th to 75th percentiles range from around about 65 up to almost 90%. And for integrated ventilation, local exhaust ventilation, similar sort of picture. But when you come to look at mobile LEV, like the flexible arms that we saw in the previous slide, then the efficacy is much less, and typically is only around about 50%. And that's primarily because it relies on a lot of diligence on the part of the operator to position the entry to the ventilation appropriately. We have just submitted a research proposal to test the efficacy of these systems, but I think what we really need to do is think about improving the entry for these kind of devices. And although this isn't really dentistry, these are taken from a study looking at intubation of patients where the work was done on dummies. But you can see on each of the photographs, there's a mask type device, which is either located in the forehead on the left-hand side on the center diagrams, or on the chin on the right-hand photograph. And the researchers looked at the effectiveness of their system by measuring the aerosol concentration in the vicinity of the process through some sort of simulated coughing process. And you can see that the red line, which is the situation with no ventilation control, the concentrations are much higher than when the device is placed on the forehead, and very much higher than when it's in the chin position. And in fact, in the forehead, the device has about an 85% efficacy, and on the chin is probably in excess of 99% effective. And I think that's the key here. We need to work towards developing new and innovative ventilation for the kinds of procedures that are being undertaken, that can position the entry to the ventilation as close as possible to the source, and to make it as reliable in terms of containment as possible. And the reason that the chin system works so well, as you can see from the photograph, is that it actually partly covers the mouth, and so partly covers the source of the contamination. So I think efficacy is really very important to understand, and it's not something that's really very well assessed. And in our study, we're trying to assess the efficacy in terms of reducing aerosol concentrations, which we plan to do using a surrogate aerosol. just in the same way as that NIOSH did with the ventilated headboards. And we want to look at the reduction in contamination around the source using fluorescent tracers, much the same as we had for the dental study. And then we want to integrate these two types of measure in the kind of models that Lisa has been describing earlier today, to try and assess the overall impact of the control measure on worker exposure. And then finally, these systems need to be tested in real life to assess their efficacy. And it's well known that efficacy estimated in controlled laboratory conditions is generally very much greater than that which you would find in real life practice. So to finish then, I think source controls are an important omission in almost everything that people are doing around SARS-CoV-2 control. Most people just seem to jump from upstream to personal protective equipment without even thinking about what might be done in between. And that's a major omission. And I hope that one of the things that we can see as an outcome of this pandemic is a greater focus on practical control systems in the future. These systems exist, but they're generally not used, mostly not fully validated, and certainly not exactly designed to be the most effective that they could be. What we really need are systems that are off the shelf, that can be purchased by healthcare providers, and that these systems are endorsed as part of routine clinical care. Well, thank you very much. I hope that was interesting for you.
Thank you very much, Professor Cherry. That was the information was really great. So that you shared with us. I decided to let it go on a little bit because, the value in this session is all this amazing information that's being shared, and there's a lot of questions in the chat box that we can sort of address later on when we go. So I just wanted to make 2 points here. It's really important that, as these controls are put in, that they're evaluated for the effectiveness, the efficacy. And I just also want to ask everyone on the call, on the webinar, if they have any examples of, success stories with some of these innovations and technologies being provided, please share it with us and we can sort of present it back in future webinars. Now, what I'm going to now do is pass you on to Dr. Simon Smith. And I know you were having trouble uploading your presentation. Is that still the case, or are you able to? I've got it as a backup here.
Yep, can everybody see it? I'm sharing the screen, I hope. No? Okay, I'll try again. Thanks. Share and... Okay.
Something's happening. There it is. Perfect.
Good. Okay, thanks very much. Sorry about that. No, the problem I had was that during this, there's a thunderstorm here, and I thought I might lose power and all connections, but it's moved away now. So thanks very much. And thank you again for inviting me to speak and for the generous introduction at the start. I'm afraid I'm very aware of the time, so I'm going to skip fairly quickly through a presentation. There are quite a lot of slides, and I hope people will be able to review them offline later on. But the subject is selecting effective respiratory protective equipment for SARS-CoV-2, and I'm focusing on the words effective and on selection. So running through, I suspect that a lot of this may be familiar to people who are in the occupational health business. When it comes to respiratory protective equipment, there are a range of products available, and these can be chosen according to the hazard, according to the task, and the needs of the wearer. Here are examples of some, and roughly what you might call a sort of 1 to 5 scale of hierarchy in terms of level of protection, and the assigned protection factor, which is used in calculation in particularly situations where there are exposure limits of the protection level needed. When it comes to respirators, you really make a choice. Sorry, I'm just trying to move that ahead. Where you have a balance between such factors as the physiological burden, the user logistics and training, and how long you can use the product, also the price, versus the protection level. And in general, the higher the protection level, the more burdensome and the more costly the equipment. So it's a matter of selecting what is needed according to wishes. Filtering face pieces at the far right, of course, are the easiest to use, but offer the lowest level of protection and have a fairly limited usage time before they become difficult to use. SCBA on the left, we don't consider any further in sort of the healthcare side. It offers the highest level of protection. It has limited service time and also is very pricey. But the options for healthcare seem to be in the range of powered air, going down through full face mask, loose-fitting powered air, and then half mask and filtering face pieces. So what you need in a workplace, I guess, depends on the hazard that you have, as I said, the tasks and the nature of the worker. Some important points to consider right up front, because in this time, there are a lot of claims, a lot of quick experts in the field. No respirator can provide 100% protection. Any claim is suspect. They don't prevent infection, but a properly fitted, maintained, and approved respirator can reduce the chances of getting infected. Discussion in the respiratory protection community is that surgical masks and procedure masks that do not seal to the face are not considered respirators. That's a quick demonstration there that fitting one's hand over one's mouth is probably as effective for inhalation as a surgical mask. We do recognize that for exhaled particles, surgical masks and other types of masks do have a role. Just some on the right, some things we're not going to mention because they're already discussed or not relevant in healthcare. Try to keep it simple. Really, when it comes to effective respiratory protection, there are 3 Fs: filtration, fit, and function. I'm sorry, I'm going to go fairly fast, but you see on the screen there are some of the terms that are associated with those. This is like the triangle of fire. You need all 3 of these to have effective protection. A good filter, the equipment has to fit properly to the face to provide the necessary protection, and the wearer has to be able to function while wearing it. And not in the case of the picture, they actually have to remove the mask to speak effectively and so on. So there are these 3 aspects, and I'm just going to focus a bit on each and give some more detail. Okay, I'm going fairly fast. You may or may not be familiar with the mechanisms of filtration. This is sort of standard industrial hygiene textbook, but it may have been a few years for some people. So in terms of the way filters work, there are generally fibrous mats in the effective areas of filter webs, and there are multiple mechanisms by which particles are removed. Maybe by grazing by, colliding with, or being pushed by airflow, air movement to a fiber, where they are retained generally by electrostatic charge. And what has been an advancing technology over the last 20, 30 years is actually to enhance the electric charge on fibers and so improve the removal of smaller particles. The overall effect of these factors is that a filter is not like a T-strainer or a net. It doesn't filter down to a certain size. And one would note that sometimes you see claims that, oh, but we filter down to 0.3 micron. It's actually more complex than that. And so the filter measurement is made with specific equipment under specific conditions. One thing to mention with these specific charging methods that improve the removal of small particles, oil can dissipate or coat the fibers, dissipate charge or coat fibers, and so there are some tests that are requiring oil mist aerosol testing as well as the inorganic salt that's normally used. Sometimes there are distinct classes. And this is where you get some of the classifications that you may have seen in describing filters. But what the effect of these multiple removal mechanisms is in the diagram there, that there are some effective at small particle size, some effective at large particle size. And so you have an issue where instead of a cutoff, there is in fact a minimum level of efficiency. And test standards have been designed so that testing is undertaken at that minimum level. And the 95 in N95 indicates the efficiency at between 0.2 and 0.3 microns, which is the most penetrating particle size in the sort of airflow ranges we're dealing with for respiration. And so at smaller or larger size, the filters are more efficient. And as we learned yesterday, when it comes to things like viruses, They are generally not free in the air, but traveling within droplets. And so the droplet size being much higher than the most penetrating size, we have effectively 100% filtration, or very close to it, at the typical droplet size that may be encountered in a healthcare situation. Top right, there's a sort of matrix of filter types and efficiency under the NIOSH classifications. That's the approval system we have in North America. N95, of course, is a very familiar term. I would emphasize it's a test standard or test classification. It's not a product. There are several filter designs that can meet N95. The other one is P100. That's generally more found in industry, but the P100 filter is certainly readily capable of meeting healthcare needs. There are other ones in there, and what happened, this classification came out about 25 years ago to deal with the fact that some technologies could not cope with this oil mist. Over time, technology has advanced, and so the capabilities of filters have sort of migrated to the extremes, so that now you will be very hard pressed to find anything else except an N95 or P100 type filter in a sort of filtering face piece or negative pressure filter mode. You will generally have to select between those. As I mentioned, the P100 is perfectly capable. On the powered air side, in fact, about 3 months ago, there was no choice. You had one class, which was an oil mist tested filter, and went on powered air purifying respirators. Was certainly capable in the healthcare side, but it also had to meet a tough classification for heavy industry where it's clogged up. And that has led to equipment being larger, heavier, and more expensive than it needed to be in healthcare situations. NIOSH responded very quickly to the issues here, and in April issued a new standard for those 100N and 100P classes, which actually will lead to smaller, lighter, and cheaper equipment in healthcare. This is a very new development. They're still actually seeking public comment on that. So this is just something good. The other thing to mention is that there are surgical mask designations, but these are generally for fluid resistance. And when you look at the test standards, they are much less stringent than the respiratory protection standards. And so therefore, for bacterial and blood resistance, there are some products that actually combine both capabilities, and NIOSH and FDA have worked together to issue a common approval mechanism now. There's nothing approved in that area yet, but in the future you will see N95 effort filters. I think on one page I have a reference to those standards. Sorry, just trying to get this to advance. On the fit, and there are, again, there are many factors that determine fit, from the design of the mask and how flexible it is to fit different head forms, the sizing options that are offered, the airflow resistance of the media. Interestingly, there are cases where you may have a more efficient filter, but because it's harder to breathe through, the air channeling through any leak is exacerbated, and you may get a poorer overall level of protection than you would with a lower grade filter. And there's some recent papers describing this. Straps are important. On one point, as has been observed when they have been examining stockpiled equipment and how it has aged over times that may be much longer than the intended storage life, is that when the filtering face pieces are evaluated, it is generally found that it is the straps that fail first, rather than the filtering material. So it's something to bear in mind if you are in a position where you are using old stock, to check the straps as well as evaluating the filter material. And again, there are guidelines on how things should be stored, and sampling done on the national stockpile in the US that have come up with information around this. Table below, I won't go through it now, is sort of covering how the features that may fail on storage or on decontamination for reuse of filters, and things that need to be checked for that. On fit, I think everybody probably is familiar with the need for fit testing. Just to say, there are qualitative fit testing using a hood and a bitter or sweet aerosol, or a quantitative test where a electronic device is used to measure dust particles in the air in the ratio inside to outside the mask. Those two tests are, one or other is used for initial selection of a product or a wearer, and for routine retesting on an annual or 2-yearly basis, depending on the where you are. It's not necessary for testing every shift. came across a case in the UK where they had been doing a qualitative test every shift. They had not been changing the bag between users, and that led to multiple COVID infections in a healthcare team. So for each donning, you practice is a user seal check, which is to cover the filtering element and then breathe in or out quickly to see if any leaks can be sensed. That's about it for fit. On function, there's been some recent work by a group called the Centre for Evidence-Based Medicine, UK-based group, and have been involved in some review papers they've been writing. One relevant one is concerning the use of disposable and reusable respirators and the impact they have on the function of the healthcare worker doing necessary tasks that occur during a pandemic. We looked at standards, we looked at the aspects affecting the fit of the respirator, how the respirators were perceived, and how performance was changed by the respirator use, what tasks were affected. This was a systemic review, and so there is a formulaic method used for that. Right now it's been submitted for publication. There's a preprint link at the bottom, and a lot of references within the preprint that sort of will provide further insight. What was found, perhaps not a lot of this is surprising. There was a need for appropriate fit testing and training, and it is not uncommon that the first respirator tried does not work well, and so one needs to try different models. One cannot go from that seal check and predict proper fit easily. You have to do the appropriate fit testing, and beards, facial hair is a problem with properly fitting respirators. When it came to certain activities, CPR led to failure of fit. There's a lot of energy and movement in CPR, and so that did lead to displacement of a respirator on the face and loss of proper fit. With powered air, that's powered air purifying respirator, there weren't any studies. Sorry, there was no failure rather, sorry, and no studies with elastomeric respirators, but it has been observed that certain activities like that can be a problem when wearing filtering face pieces. When it came to standards and practice and training, I think the key thing is that repeated training was necessary. It wasn't good enough to do it once a year or just when the person started in their job. Repeat training was essential in order to ensure that safe and good fit was obtained and safe use of respirators continued. Doffing and donning is a key aspect, of course, to make sure the respirator is worn and fitted properly, but also during doffing to make sure there is no cross-contamination due to loss of infectious material from the respirator itself. On the impact on performance, there were some studies using simulations, and it was noted that intubation was minimally affected by respirator wear, but there were some problems with vision and hearing, as might be expected, and that depends on the nature of the respirator. On communication, there is a drop in speech quality. Again, not surprising. There are speech transmitters incorporated into various kinds of the elastomeric masks, and so this will aid that situation, but it is, again, going to be an issue with some kinds of respirator. On comfort, simple fact, respirators are not comfortable to wear, and it was actually noted that it was higher discomfort with the elastomeric face piece and the powered air systems than the filtering face respirators. It was reported that half of users were unable to wear for a full 8-hour shift, but that was a highly variable observation.
Simon, yep. It's Kevin here. I'm just wondering, I just wanted to leave
yep.
room for at least one or more questions, and
yep.
just wondering if you could wrap up soon. Thank you.
I will, yes. Okay, thanks. Okay then, overall there's a balance accepted between discomfort and protection. On standards, there's more slides, but what I will cover is simply to say there are performance standards, and there are a range of these, and in supplementary slides you will see more information about these. So that now with shortage, there are non-standard or non-familiar standards in use, and some of these are better than others. When it comes to selection, there are standards, and particularly good standard in Canada guiding selection, that have existed for some time, but also emergency changes under the pandemic planning. links there to Canadian and US connections. Canada does have a very good standard for selection, use and care of respirators, which includes a system for selecting appropriate respirators for biological aerosols. Again, that's detailed later. And just to say a few current issues to be aware of. It is possible and now allowed under various authorizations to use any industrial respirator in healthcare. Extended use and reuse is a fact, and there are technologies, again, rapidly developed for that. And things to be aware of in using unfamiliar respirators like counterfeit products, or in particular products that may fit a standard but do not fit well to the wearer because of different head shapes between say, Asia and North America. So with that, I'll stop there, and I guess we'll move on to questions. Thanks.
Thanks, Simon. And I might, if you don't mind, if you just leave that slide up that you just had up there, the one that you just had up. And I thought I'd just lead in with a question from Marianne. And first off, I want to thank all the speakers. And we haven't really got much time for Q&As, but I just wanted to bring everyone's attention to a question in the chat box from Marianne Levitsky. And I'm just putting this to all the speakers, maybe Lisa and yourself, Simon. And I know we're talking about the hierarchy of control. So really we should be focusing on, engineering controls more so than respiratory protective equipment, which is the last line of defense. But this question has to do with, in the webinar yesterday, Dr. Conley said that he had evidence and experience showing that healthcare workers wearing surgical masks to care for COVID patients were not infected. Can you comment on this in light of what is known about the effectiveness of surgical masks in comparison to N95s and other approved particulate respirators? Do you think that good ventilation in hospitals, in light of Dr. Bross's comments on infectious dose, may explain this? Maybe if I go to you, Dr. Brosso, first, if you don't mind, if you're still here.
Sure. It's hard to prove a negative. So I'm sorry I did not listen to Dr. Conley's presentation, so I don't know what data he's basing that on, if it's anecdotal. The studies that have compared surgical masks and respirators, the clinical studies that have compared those two for influenza and influenza-like illness most of them have not had a control group. And so it's very, the conclusions have often been that those two types of, personal protective equipment, I use that term broadly, are equivalent, but it is actually very likely that the respirators didn't work because they were not fit tested or were not worn. And that is a problem. If you don't wear a respirator when you have an exposure, it will not work. It's very likely that surgical masks, didn't work. So you would get similar kinds of, performance with respect to those two. But if you don't have a control group, then you don't compare what happens without either of those interventions. You really can't make a whole lot of conclusions about one being just as good as the other. What you can say is that neither of them was different from each other. But that doesn't mean that they're similarly as good. And if you actually look back at some of those studies, you'll see that the rates of illness are similar to what you would see in places that are not using either surgical masks or respirators during influenza, seasonal influenza. So I guess I would say that I don't think there's very much evidence that surgical masks provide any kind of protection. And as Simon just mentioned, they are not respiratory protection. They do not fit. Their filters do not work very well. I've measured the filter efficiency of surgical masks. It's all over the place, but none of them come close to being what we would expect for a respirator filter. So there is very little chance that they provide very much protection, and probably what is happening is simply by chance, or maybe someone is not in the room long enough, or, so I don't think the anecdotal evidence is appropriate, and I don't know of any clinical evidence that suggests that your surgical masks are appropriate.
Thanks, Dr. Brossu. We've got 1 minute left. Simon, would you like to comment on that?
I just can't comment on that question. It is also a factor that you're looking at the working hours, or trying to control with one type of respirator or a surgical mask during working hours. We have no control over people getting infected outside work, or again, as Dr. Brossu mentioned, whether they're properly wearing a respirator, because they're not going to admit that they're not wearing it properly or wearing it as they should. So this is the comparison I've used is like it's trying to test by make people wear a seatbelt 1 day a week, if seatbelts are actually effective in reducing road accidents, road injuries, because you have so little control over this. And there have been multiple studies, and when statistical methods have been applied, as Dr. Brossu said, you don't get a good conclusion out of that, even if sometimes papers have claimed it. And sometimes the authorities have grabbed onto that information and sort of taken it into a policy.
Great. Thank you very much. So we've just hit 2 o'clock, and firstly, I just want to thank all of the speakers. And there's been a lot of chat, and we're very grateful for your generosity, Professor Cherry, Deborah Gold, Lisa Brossu, and Simon Smith. I don't know if you're prepared to stay on a bit longer. If not, we understand, but if you want to stay on a bit longer, maybe we can have some more discussion. Otherwise, like I said, we're really grateful for your presenting and being generous with your time. And I especially want to thank the OCO team that supported this, and also Alec Farquhar, who's been the catalyst behind these sessions as well. So we might just keep the channel open anyway, for those who want to carry on talking, but just the session is actually officially finished, but we're going to keep on talking if people want to stay on. And I don't know if Deej or John are still on, if they wanted to comment on that last question, or maybe we can move on to another question. I think it was pretty well answered, unless either of you want to make a comment on that, the United Kingdom position perhaps, or the Californian position.
I can comment on the effectiveness of respirators. I mean, we reviewed a lot of studies in writing the standard, and we've relied also on, in experience of NIOSH and everybody else. A lot of, even studies that have been cited by the people who don't support respirator use compared to surgical masks have found differences in influenza-like illness, even though they claim to not find a difference between the two things. So I think that I think in some ways this has become a political issue and is less of a science issue, because we know as industrial hygienists, we know what it takes to prevent the entry of particles into the respiratory tract. And we would never say, go out and grind that silica or, work with that lead with a surgical mask on, because we're going to inhale lead particles or silica or whatever it is. And I think that should be sufficient, but I do think there are clinical studies that do demonstrate the difference.
Yeah, I know there was I'm sorry, John, over to you.
Yeah, I was just going to say, I think, I agree entirely with everything that's been said. And I usually try and put it in this sort of way that, if you're going to send your mother or daughter or whatever into a ward where they were doing aerosol generating procedures, which would you choose, the surgical mask or the respirator? And I think, without exception, people choose the respirator because it's this, you really have this conservatism built in. You want to ensure you get the best protection you can in amongst all this uncertainty.
What we're seeing, though, is a lot of the procedures around AGMPs, and it's the non-AGMP exposure that could also produce, be a risk from somebody coughing, for example. So, if we lock into those AGMPs, and I know I've spoken to Lisa about this as well, that's a concern.
Well, it is true that, hospitals do have higher rates of ventilation, and that may be helpful, it may be helpful in those contexts, but most other workplaces do not. Again, I want to point out that there's actually been very good work with tuberculosis, and in fact, there are CDC guidelines for tuberculosis in homeless settings and in settings of incarceration, and they don't talk about the use of surgical masks. It's not even a discussion item, and it's not a discussion item in healthcare. So everyone says, okay, well, tuberculosis is not like, it's a bacteria, but there are so many things about tuberculosis that are like this particular outbreak. If you look through the literature, you will see clusters. You will see descriptions of outbreaks where one person who's infectious with tuberculosis goes into a bar, and everyone in that bar or many people are infected. The analogies are very appropriate. It's an aerosol. It's generated by speaking, by talking, by breathing, by coughing, by sneezing. It's a very hardy aerosol. It stays alive in the air for long periods of time. It is both aerosol transmissible and airborne in the context of the definition of airborne. And I think we need to start thinking about it and going back to what we know about measles and tuberculosis and start thinking about it in that context, because we've done a lot of solutions for especially for TB that are very relevant today. There's discussion of UVGI, UV germicidal irradiation. There's lots of research around that, and it works well in some contexts.
Just mention something on aerosol generating procedures. Thanks very much. In again the Canadian standard, we have gone into a selection guidance for biological aerosols. We recognise that the ambient airflow, air changes, actually are to be considered in selecting the type of respirator. And so, although I might use an N95 type filtering face piece in areas with high ventilation with an aerosol generating procedure for SARS-CoV, if the ventilation is poorer, say it's being done in a patient room or leads in the corridor, if things get that bad, a higher level of protection will be recommended. That will mean going to powered air purifying respirator. And so some of us in the community aren't even comfortable with an N95 type product. There's a blanket provision for aerosol generating procedures.
The other thing I'd like to say about respirators is that, we're all, and I, congratulate Simon on highlighting the fact that, N95 filtering face piece respirators are the bottom of the respirator hierarchy. If we had, and there was a good IOM, National Academy of Sciences study and report about different kinds of respirators during pandemics, and they discussed the fact that elastomeric respirators might have a very, key role. And if we had or were to purchase an elastomeric respirator for every single frontline healthcare worker or healthcare worker in general, we would alleviate all of the supply issues. And not only that, we would have respirators, like N95 filtering face piece respirators for everyone else, because we have so many other workers who do need. I mean, we cannot solve the problem for every single worker with ventilation. There are those who in essential work, workplaces and doing essential work that need respirators, but they're being told you can't. And so what they're being told is to wear face coverings, because we can't even give them surgical masks, which I wouldn't, there's not much difference between those, but face coverings is even more ridiculous. They don't even come close to being a personal protective equipment. But now you see, not only does CDC recommend them, they're now starting to say that workers should wear them, and workers should wear them if they can't physical distance. These are egregious recommendations. We should be holding their feet to the fire and saying this is unacceptable. This is not how we protect workers.
Thank you, Lisa. And just on that, so last Friday with the point of care risk assessment webinar that we provided, You know, people that are doing a point of care risk assessment should be asking questions about ventilation. So that should be part of the point of care risk assessment. What's the work environment like? And there was so just taking the discussion away from respirators, I can't find it now, but I think I can remember it. Val Wolf asked a question, you know, with the calculations that you provided, Lisa, and Val was talking about occupancy. You know, can the calculations that you provided help us make decisions about occupancy?
Sure.
I think I've captured that.
Yep.
In congregate living.
Oh, sorry.
Sure. You can easily, you know, if you can figure out how much one person generates, you can add more people to the mix.
Okay, thank you. Let me think. Another question. So the hyperlink's been put into the chat box around the ATD standard. Thank you very much for that, Dorothy. And there's a lot of discussion around. I'm just trying to find something that's a little bit more. Regarding probability calculations for infective dose, over what time period of accumulating variants should we be concerned? It would seem that total number of variants exposed to over months, years, lifetimes would not be important compared to the accumulation in a given hour or at a single moment for a particular exposed person, such as the hotel room cleaner. Put another way, at what time interval does the body forget it was exposed to a given variant? Oh.
So that's a good question. Can you hear me, Kevin?
Yes.
Yeah. You know, it's a good question, and it's one I don't have an answer to. So and I think someone else asked the same question earlier, that is it an acute exposure? Is it a chronic exposure? I don't know. We do have defenses. You know, we have defenses to fight against infections. So it probably is not a chronic exposure, but it's probably not a long-term 4 to 40 hours a week, 40, 20 years of working or whatever it is. But I've been making my calculations on the basis of a day, a working day, for example. Seems a reasonable approach. If you're worried about trying to control someone's exposure, let's focus on a day. Maybe it's a week, but maybe it's, I don't know. We don't know the answers to that. Nobody's done the animal experiments that would elucidate what is the nature of the exposure that leads to infection.
Thank you. And I just want to make a comment there. We've talked about ozone generation. We've also talked about, ultraviolet, UVC as a sort of a disinfecting agent. And the issue here could be that we could be exposing workers to other hazards. So rather than go and introduce this kind of technology, they really need to do a risk assessment around the exposure to those things as well. And I know you did say that UVC is very effective, I guess within, say, ductwork, for example.
Well, the problem with UVC is, my understanding is that it's pretty good with TB, but it's you need a longer contact time for it to kill a virus. And so that's the piece we don't really know yet, is what is the length of contact time needed with UV. So it may be that you have to adjust what we know on the basis of a different organism.
And
okay,
used,
and
can I say something about UVC? Because they used it during the AIDS pandemic before we had drugs, and they used it at San Francisco General upper room UVC for people who were getting aerosolized pentamidine, because they may also be infected with TB. And there was some suggestion it would be that upper room UVGI might be useful, but it is incredibly important in designing, what Lisa said, it's incredibly important in designing UV that you have the air circulation characteristics that are going to support disinfection. And in most circumstances, we don't. And in most circumstances, we don't have the expertise to actually design them. So So, you know, that's just a concern. It's not like plugging in an air filter. And even with plugging in an air filter, you have to be sure that you're actually getting the air circulation by the air filter that allows it to provide effective room cleaning. So a lot of times we do see hospitals bringing in a portable HEPA filter, but we don't know that you're actually increasing the air changes, the effective air changes per hour by doing it.
Yeah, so you need to measure.
Right. You need to measure, you need to design. And
Right.
like in school situations, one of the things we're very concerned about now, there are like a real lack of knowledgeable maintenance people and engineering people in any school system, at least in California. Maybe it's better in Canada.
Thank you. I've got a question. I've got a comment here from Nancy to everyone. AII rooms, so the infection isolation rooms in a large Toronto hospital during Ebola were found to have been operating at positive pressure for years. OHS expertise is wanting in the healthcare sector. So, you know, I guess in these units, these critical units where the COVID patients, you know, the hospitals really need to look to make sure that they've got the proper kind of isolation in place with the negative pressure. And I think they talk about 12 air changes per hour. I don't know if anybody else wanted to comment on that. From Nancy.
The health department did a similar study in Oakland, California, of a public hospital there back in the 90s and found pretty much the same thing. And we find that a lot when we go to airborne infection isolation rooms, is that they often are not either providing the amount of airflow, or they're not under negative pressure, or they're not being used. They're using the wrong doors for entry and stuff like that. There's a lot of problems with them, with making sure they function correctly.
Great, and I guess you know, with the World Health Organization about to review their position, and I hope they do, you know, thoroughly. You know, there's going to be so much more focus on ventilation and higher order controls. So, you know, we know that there is a high likelihood that it's airborne. So really, we should be now focusing on making sure that all those controls are in place. Now, I did. I lost my train of thought. Sorry. I was going to say something. Oh, yeah, there was a question to John, to Professor Cherry, about how long the efficacy tests would take. I think you talked about efficacy of different controls, the localized exhaust ventilation controls. John, are you still with us, or have you left? You might have left.
Yeah.
I'm just wondering, has anybody on the line got a pressing question they'd actually want to ask themselves? As I said, we've got a lot of questions here, and we can actually go through the questions and, you know, really try and, you know, be reflective in providing some of the answers back. But it's always useful to have someone on the call ask a question in front of everyone else. So I'm just wondering if anybody would like to do that. Are we able to do that, Tony?
People can unmute themselves.
If you want to unmute, anybody wants to unmute themselves and ask a question?
Just one at a time, though. I guess I have a question about congregate living and maybe Deborah, from the Cal OSHA perspective. We're doing a lot of work with migrant farm worker trying to promote COVID prevention. And it's very challenging with the living conditions here. And I know that it occurs elsewhere in the US, and you referred to the prisons. And I just wondered about any solutions or any sort of advice, potentially using some of the calculations that Lisa showed around limit, you know, 4 to a washroom limit. I know that there's spatial and other design or minimum air changes, things like that. Anything that's available that we could apply to that population and that risk?
You know, there was a presentation by the Migrant Health Support Network, I think it's called, or Migrant Health Network, maybe, that looked specifically at conditions in ag and for farm workers, including this whole issue of what would be peri-occupational exposures, both living conditions and transport. And, you know, because people are loaded in the back of vans, you know, closed up vans and transported to work sites, whether that's legal or not, which in California, it might not be legal, and in the United States, it might not be legal because there are regulations about transport of workers. But nonetheless, that is what happens. And, you know, so it's really hard. But like I said, there are people trying to address it. I don't, you know, so I mean, it is a problem, and it's likely to be part of the problem in all of these other outbreaks. Congregate living is a little easier for us, you know, whether it's licensed, because there are some recommendations from California Department of Public Health on congregate living facilities that, you know, address issues like separation between infected and non-infected, separating the staff who's going between infected and non-infected. That's been an issue with the federal prisons, with the state prisons. That's what I got to say.
There's a comment here in the chat box from David Abrams to everyone, and it's something that I've noticed too. When you're out there in the public, you know, and you see people wearing you know, face coverings with ear loops, and there's also been respirators that have been marketed with ear loops. But ear loop, and so David Abrams says to everyone, ear loop masks are not respirators per se. A respirator needs to have straps high and low to achieve a good fit. I think it's critical, like, you know, you're trying to look at what works and what doesn't work. And I know that, I think it might have been certain types of respirator that came from China had ear loops. And I did speak to Simon about this, and he provided a lot of good information back about that. So, you know, just some information. I think also Kimberly asked a question about the evaluation of you know, the impact of decontamination on respirator fit. So we're just going back to respirators again. So, you know, if we do decontaminate them, is there a, you know, do we change the way that they'll fit? And I know Workplace Health Without Borders, they were talking about leaving a respirator for 7 days and then almost like rotating through sort of 7 respirators and then going back to the first one. But I don't know, if anybody wants to talk about that. If you've muted, Deborah, I think.
So, Kevin, I did work on, I did write an article about decontamination and did review several of the decontamination methods that looked most promising. But my big problem with decontamination is that we have some data that suggest that filtering face-piece respirators, and I think Simon mentioned this as well, you know, after some period of time begin to lose their ability to fit, and it's because they're not designed to be donned and doffed multiple times. The straps will give way. It'll be harder to just the very form of the respirator loses conformity, and you know, the nose clip starts to fail, and all of those things are really important in fitting a filtering face-piece respirator. So the data suggests that after 5 to 10 times a donning and doffing, that's when you start to lose the ability to fit a filtering face-piece respirator. Well, that really doesn't make decontamination very cost effective. There's a huge amount of logistics and other things that go into managing the decontamination of a respirator. But the other piece of the puzzle, I think, is that none of these methods have been really well evaluated with respect to either filter efficiency or fit or long-term comfort. There's a small amount of data and just a few studies. Some are peer-reviewed and published, some are not. And yet, and I have to tell you, it was never anything I ever saw. We never discussed in the context of pandemic influenza planning. So I was pretty shocked that people were talking about decontamination of respirators. It's not what we should be doing. it actually, I don't know what Deborah would say about this, but in the context of NIOSH certification, anything you do to a respirator negates the certification. I know CDC and NIOSH have said, well, in the very extremist circumstances, you can do this, but they do not recommend it. It is really truly a last resort. And you did mention the reuse reuse over time with leaving a respirator. That's actually a suggestion that CDC made, that you give a healthcare worker 5 respirators. They rotate between those 5 respirators and simply don't, by the time you get back to the first one, whatever's on that respirator has lost viability. That's a much better solution, I think, if you really need to reuse respirators than decontamination.
Thanks, that's
yeah,
great.
I agree with Lisa, and also there was a UCSF study done recently looking at reuse and extended use as and the ability to provide the fit factor required, right? And they came up with some recommendations on limitations of both extended use and reuse, and that's without adding the stress of decontamination. I don't know, I think that's a pre-publication study, but it was pretty, it was pretty limiting as to how far you could go with these strategies and still provide the protection that people need.
Thanks, Deej. Just there's a comment here from Maria Possumai to everyone, and this is a really important comment. Hold on, no, it's not. Is it? Yes, it is. The surgical mask versus N95 respirator studies, especially the ones by Loeb and Cito, are being used by PHAC and WHO as bedrocks to their arguments. Should there be papers and studies that address the studies on summarizing the arguments set out today by our excellent experts? I'm not familiar with Loeb and Cito, but obviously there's papers there that PHAC and WHO are using as bedrocks for their arguments. And I think it's very important, we try and get our hands on these studies just to show that, surgical mask isn't personal protective equipment, and to demonstrate that there is a difference. So we've got, I think we might fold up at 2:30. I don't know if there's any closing comments from any of the speakers that are still online, from yourself, Deej, or Lisa, or Simon. Just closing comments from yourself that, gems, words of wisdom that you want to leave the group. This is being recorded, and like I said, the questions are going to be pulled together, and we're going to try and provide a kind of more of a kind of concerted response to all of them. So I don't know if you want to share some closing comments. And I just, like I said, thank you so much for fabulous involvement from each of you. Thank you. But if you want to, any closing words? Not from you, Deej, Lisa?
I guess my closing comments are that we, as occupational health and safety professionals, really need to work together. We need to convince people that aerosol transmission is a real thing. It's important. It's an important mode of transmission, and it requires more than face coverings and even respirators. It does require exactly what we've been talking about here, more attention to the other parts of the hierarchy of control, source controls and pathway controls. But the answers are not simple. A lot of these questions people are posting, tell me what I should do in this situation. What should we do in this situation? Unfortunately, with aerosols, it's a little bit more complicated, but I do think we have the solutions. I do think there are solutions out there. It will take all of us to work together using the instruments and methods and modeling that we have available to us, that we've used in many other settings, including complicated ones like pharmaceutical aerosols and nanoparticles and other similar problems. And even if it's just control banding, there are ways to solve this problem that don't require that we tell everyone to wear a face covering, because that's not the solution. Thank you.
Thank you. Simon.
Thanks. I think I was muted there. I couldn't speak. I had a couple of comments about the Loeb study you mentioned. That was examined in the Canadian standards development, and we found that it was not powerful enough statistically for the conclusions that we drew. And it's a shame that it's being used by authorities now in making protocols. But thanks so much.
Sorry, just on that, Simon,
yeah.
Would you mind responding back to the question on the chat box then? Like maybe you can provide a response on that, what you just said later on,
okay.
You know, after it's great, that'd be fabulous. Thanks.
I'll try, yes,
okay.
I'll try to. Thanks, yeah. And just, I guess, to conclude, thank you very much again for the opportunity to present. And it's, I guess, very, very fast moving, very, very interesting area. If anybody has any questions, I'll have my email on the presentation, and be happy to share this and other information I've included in the extended slides in the presentation. But thanks very much again.
And just for everyone's benefit, Simon also presented through Workplace Health Without Borders, and that's also on YouTube. And Simon also presented to St. Michael's Hospital too, so that's also been shared as well. And we're very grateful to have Simon also share his knowledge with us as well. And just going back to Dr. Brossu also, we're very grateful, and also Deej. I mean, it's really, hopefully we're breaking some new ground here. We're trying to make some changes in providing this webinar. And without any more comments, I think we'll close the webinar. I just want to thank everyone for great participation and questions, and to our presenters. Thank you.